comprehensive eye health. And I invite the, the ophthalmologists on the dais, Dr. Jaideep Datta, Dr. Vinod Kumar Chawla, Dr. Parul M. Sharma, Dr. Sarita Agarwal, Dr. Nutan Kumar Darda. None is there. Then I'll request Dr. Arup Chakravarti. Please be on the here as well. You present also. Dr. Arup has been my mentor also for my IELTS training long back, 94. So how can I be there in the chair only? So we start with, first presenter is Dr. Arvind Kumar Maurya. Is not there?
He's not.
Dr. Renu Hashia, you have some, you want to do
I
earlier?
have to connect another instrument.
What's your good name?
Dr. Kunal Ashok Shinde.
Dr. Kunal.
Yes.
Please
Ashok Shinde.
stick to your time, please.
Yes, yes.
Right?
First of all, I would like to thank the AIOS for this wonderful opportunity to present me, and it's my fortune that I have learned from Dr. Mansi ma'am from Vivekananda here in Dehradun itself. So my talk for today is this innovative approach in surgical training. So why it is we need the innovative approach? First thing that we have a lot of MS seats and lot of DNB seats, and for a one fellowship seat there is a 30 applications. So surgical training is really difficult in nowadays, and we need a good institutes and good trainers for this purpose. So it is to be done how? What is the innovative way to done it how? So I compare always, I tell my students, now I am a consultant at HVDS and I teach them. So it is learning like a bicycle. How we learn a bicycle? You can see the observation, preparation and experimentation, all this cognitive learning behavior. So what is in observation? In observation, the old one is to have the microscope and students are standing out there and they are watching, but it is nothing, we can see nothing. So the latest is that you need a recording system, you need a monitor, and that then you can display it. So what to observe? By trainee, he has to observe how the surgeon is doing the surgery, how is his critical thinking, and how he holds his instruments, not in a microscope, but in a real way. And what trainer has to see in a trainee, that how the trainee is dealing with the cases, what is his logical thinking procedure when he is doing that, and how he just deals with the stress in the surgery. So it's the observation is this very important. It requires a communications and difficulties. So next is this preparation. Preparation is both a mental way and a physical and a mental. It deals with the skills and knowledge. Knowledge domain. You have to make the concepts clear. And how you make it concept clear? By diagrams, like how to make a cystotome or how to make a rhexis or how to chop. Then is the analog story. Means ki for a phaco, I used to tell a student how to make a chop. So it's like holding an onion and then you cut it. You cannot cut on your hands. So when you hold your phaco piece, you have to chop it lateral to it. So it's the analog story that they remember a lifelong, and they tell me कि हाँ sir आपने बताया था तो काफी अभी remember हुआ. So concepts should be very clear when you are telling, and it's a teacher's job to make them interesting. Then resources, there are a lot of resources, textbooks, now there are online resources, videos, and it goes on. 1 minute videos, I have my YouTube channel that clears the concept in 1 minute. So this is the cognitive domain, and the psychomotor domain that deals with the old way was the wet labs, but the recent one we have at the Orbis is the visually augmented VR rooms. So VR equipments are really helpful in this way. This is the latest innovative approaches. Then now the experimentation. Third phase is the experimentation. For the experimentation, you need there should be two domains. Administrative level, that the teaching institute should have a mindset that the peoples are learning, students are learning, and they require a lot of time, so OT may run out of time. So that one mindset they should have, and they should they should have the ability to retain the teachers with the good pay. But what the unfortunate story is that good teachers are leaving the institutes because of this administration level. Then at the trainer and trainee level, they should let the trainees do the cases and observe him in details and give them dedicated time. Then there is the failure. Every surgeon must have failed. So failure is the part and parcel of learning, but don't get panic and don't shout on the complications. Handle the complications calmly and discuss the case, the way of handling such complications, and then video review keeps apart. Then frustration is a part of both the every trainer goes through the frustration. There is a phase of frustration, but it's a teacher's job to make him better. So it's to be a mentor at that time, and he has to both monitor and mentor him. And then the next step is a recovery. In recovery, I say the people that live in the present, because present is a gift. Then it's a repetition cycle. It's a whole the cycle is getting repeated, and you need a breakthrough. That is a luck. So mastery. In my conclusion, I said that you can achieve anything if you are calm, at a peace with yourself. So it's learning is always a heart, head, and hand. So I call it triple H, a cognitive domain where is a head, you should have concepts cleared. Then affirmative domain, heart, that you should be receiving, you should be valuing, and you should be accepting your mistakes. And then a psychomotor, then comes the hand, where you called it psychomotor, the reflex movement and this. So I always say surgery is done by the mind and then by the hands. So these are my ways of innovative teaching. So I presented in a non-formal way. It was not a PowerPoint. So thank you all.
Yes, Dr. Kunal, very nice presentation. And you covered, you actually emphasized on all the three domains. And now the things it is actually for having a 360-degree development. Basically, one should look for that. And you have focused on that very nicely. And this is true like for all the trainers, all the ophthalmologists, or those who are in teaching or otherwise practicing, training residents. They should actually have this passion. Yes. Passion is what required actually for training. Yes. That is an essential thing.
And it's my luck that I trained here under Dr. Mansi ma'am and came here.
Yes. Okay. So with that, we invite the next speaker, Dr. Arvind Kumar Maurya, who would be talking on an insight into the newer indications of OrthopTech magnocellular stimulator.
And my dear friends, so my talk is on an insight into the newer indications of this OrthopTech magnocellular stimulator. So vision without action is merely a dream, and action without vision just passes the time, and vision with action can change the world. So I'm very thankful to all the Indian and the international innovators who has helped the ophthalmology world. So in short, amblyopia is a neurodevelopment ocular disease manifested as monoocular and binocular impairments, including vision reduction, contrast sensitivity, or even loss of stereoscopic vision. So does it require redefining this vision which we are taking with the help of the Snellens or the Logmar chart? So there are a lot of other factors to consider. So the cerebral changes are defined by the functional blood oxygen level dependent MRI and methods of management, and also helping in the combination of treating modalities. Other factors to consider: eye-brain ability to process motion, shape perception, spatial interaction, hyperacuity, contour integration, and binocular single vision components. So what is new and future is really bright. So there is this innovation by Dr. Santhan S. Gopal. This is OrthopTech magnocellular stimulator. It's the most economical device and is the best option for treatment of amblyopia as per our world's first clinical trial. So other indications are there in the sixth nerve palsy, partial third nerve palsy, Alzheimer's disease in hyperactive children, attention deficit disorder. But more studies and multicentric studies needs to be done to more conclusive. And it has in the early recovery, and patient needs to carry only a laser torch while doing the exercise. And this has the early recovery time compared to other treatment modality of amblyopia. Even the contrast sensitivity, it improves much earlier, and the stereo acuity before the visual improvement. So what is the hypothesis? It's the top-down impulses originating in the prefrontal cortex, and they alter the attention mechanism, so it works by working on the overt as well as the covert attention system. So there is a sudden appearance of the light that stimulates the saccadic movement and is associated with the stimulation of the fovea in the V1 area via the top-down impulses. So there is suppression of the retinal area between the fovea and the peripherally stimulated retinal point to avoid the smearing effect, and repeated stimulation of the magnocellular cells in an interval of 145 to 150 millisecond via the attention area and parietal cortex leads to maximum stimulation of fovea. So this case I would like to show you. So this was a 16-year-old boy, decreased vision of 6/36 and 6/36 part, traumatic optic atrophy, near vision N12, disc pallor, right eye color vision 6/16, left eye 5/16, stereopsis more than 400 second of arc, and reduced contrast sensitivity of 1.2. Other investigations were done. The MRI shows thinning of bilateral optic nerve, vitamin B12, 222 normal range, but there was hyperhomocystinemia, and these were the visual field charts. So we admitted the patient, and we started with 1 week of orthoptic therapy, citicoline, BD, and methylcobalamin 1500 international unit, and the hyperhomocystinemia was managed by the physician by giving the tablet folic. So this is how it is done. So first for the amblyopic eye, so in this case we did for both the eyes 20 minutes alternate. After 2 weeks of orthoptic therapy, patient improved in a great way. So in right eye, vision improved to 6/12 part, in the left eye 6/18 part. Stereo acuity also improved, and near vision also improved to N8. So there is a definite role of functional blood oxygen level dependent MRI. So in the normal population, if we see the oxygenation level, and after in the amblyopic patient it is reduced the oxygenation level, but after giving these amblyopia therapy, any amblyopia therapy we are giving, we had seen a drastic change in this oxygenation. This orthoptech has also shown significant improvement in vision, stereopsis, improvement in the hand-eye coordination, improved self-confidence, reduced nystagmus, strabismus. Hyperactive children, they are performing very well in schools now, and they have better handwriting after using this orthoptech. So this is a new and novel device which can be used in many other neuro-ophthalmological disorder, although multiple clinical trials needs to be done to be more conclusive in our country. Thank you. Thank you so very much.
Dr. More, it's a new technology, like what is your experience? How many cases you have done it?
We have now, it's more than 1,000.
1,000 cases?
Yeah, more than 1,000 cases.
So it means it's published data?
Yeah, the clinical trial is about to be published very soon.
Okay.
And one clinical trial we are also doing on the functional bold MRI changes. So for that, the sample size is 59. So till now we have done 23 cases.
So VP is also included into that?
No, it's not included.
So do you think that if you include VP also?
Yes, it can be, but we don't have that facility at our institute.
No, but about those 1,000 patients you are mentioning,
Yeah.
is that VP included into that?
No.
That is all with the Dr. Santan Gopal?
Yeah.
Okay.
Yes, it is available in India. It's an Indian innovator, Dr. Santanas Gopal. I will share his number with you after my talk. So yes, it is available. Its cost is 1.5 lakh, no financial interest. And we can put it as just like a digital screen, right? So the patient need to set a 1 meter distance using the green laser torch, and these LED bulbs are there that are lightened after a second, 145 millisecond gap. So the patient need to follow it. Just it. Because what is happening at the presynaptic and glutamate inhibition, and there is no nitrous oxide release. So because this we need to do it very quickly. So this 150 and 160 millisecond is the ideal time. So we are put at this 145 millisecond gap between the flashing of light of these LEDs. Okay, yeah, so this amblyopia is just a relative term. There is no plasticity, rigidity, because we have treated patient up to 56-year-old having vision of 6/24 part, and that patient improved to 6/6 part. The patient is very happy. Yeah, for the initial 2 weeks, alternate days. So the therapy goes on for a good 40 minutes, not more than that, right? But the most important thing is some optometrist or some resident or some nursing officers needs to sit along with the children because they need to focus. Because a lot of patients, they were not improving, then I get to know that they are not focusing. So now onward, one attendant needs to be there to guide them how to do it properly.
Okay, thank you, Dr. More. So with this,
Thank you
we
so very
proceed
much.
to the next speaker, Dr. Renu Hashia. She would be talking on HBOT in ophthalmology.
About hyperbaric oxygen therapy, its usage in ophthalmology, though it has not been used much in ophthalmology, but now globally people have started using in various conditions in ophthalmology also. Primarily it has been used by Undersea and Hyperbaric Society of India for decompression sickness, and in cancer patients also they are using it. So this involves breathing pure oxygen in a pressurized environment. The goal is to increase the amount of oxygen in the blood and tissues to help repair tissues and restore normal body function. So this hyperbaric oxygen therapy is a unique and modern way of therapy that taps into the body's natural healing abilities. The eye and periocular tissues can benefit from this therapy in certain disorders. The anterior chamber, posterior chamber, and the vitreous body are filled with non-compressible fluid, which means that the eye is not adversely affected by changes in pressure unless a gas space exists adjacent to the eye or within the eye which is from surgery or trauma. Now, the physiology of eye in hyperoxic condition is normally air at 1 atmosphere absolute has an oxygen partial pressure of 0.21 ATA, and it produces an arterial PO2 of approximately 100 mg in healthy young individuals. At this PO2, the hemoglobin saturation approaches 100%, and oxyhemoglobin transports bulk of the oxygen to the body. The amount of oxygen dissolved in plasma is normally only about 0.31 volume percent, but this dissolved oxygen fraction increases in proportion to the inspired PO2. Now, how does this HBOT work? In a hyperbaric oxygen chamber, the patient can lie down in a relaxed and comfortable position with a specialized hood or mask. Slowly, the pressure inside the chamber is increased 2 to 3 times higher than the normal atmospheric pressure. A specially trained HBOT technician remains in the chamber throughout the treatment. During the compression or increase in pressure inside the chamber, patient can feel fullness or popping sensation in the ears, and this sensation can be relieved by simple equalization procedures. So what constitutes HBOTs? It is the high pressure oxygen, and this is high pressure under which the oxygen, 100% oxygen is delivered in a chamber, in a closed chamber, which can have one seat or it can have multiple chairs on which the therapy can be given to the patients. So this can be a chamber where only one patient can lie down, or you can have chamber where multiple patients can sit at a time. Now the mechanism of action of HBOTs, this is a normal blood flow where the vessel is not occluded and it goes to the tissues. But in a compromised or when there is a occluded blood flow, what happens that plasma can still flow through the channel, but these red blood cells, they block off the blood flow and they cannot go to the tissues. So as a result, the tissue break down due to lack of oxygen which are around that blood vessel. Now, what happens when you administer hyperbaric oxygen therapy? The red cells are not passing, but there is increased plasma which can carry up to 100% of the oxygen under pressure, and then it diffuses to the peripheral tissues where there was a restriction of the blood flow, and increased this plasma goes to these tissues, and in addition there can be an increase in the vessel. There can be extra capillaries which can grow from this, and they supply the areas which have reduced oxygen supply, and that is how it really works. So this is again showing the same thing, that once you increase the ATA, the oxygen dissolved in plasma also increases, and that is how it helps the patient. So now as far as eye is concerned, there are various indications where this therapy can be used. We can use it in decompression sickness, arterial gas embolism, central retinal artery occlusion, ocular and periocular gas gangrenes, cerebro-rhino-orbital mucormycosis, periocular necrotizing fasciitis, carbon monoxide poisoning with visual sequelae, radiation optic neuropathy, radiation or mitomycin C-induced scleral necrosis, periorbital reconstructive surgery, also this can be used. Many vision-threatening eye diseases are associated with hypoxia and accompanied by elevated levels of VEGF, which is a normal hemodynamic soluble glycoprotein growth factor. Whenever there is chronic retinal hypoxia, as in it can result in elevated levels of VEGF that trigger neovascularization in the retina, optic disc, and iris. Elevated levels of VEGF can also cause increased vascular permeability that can produce loss of vision through macular edema. A number of agents have been developed to block the effect of VEGF and are now being used to treat a variety of ocular conditions. So that is how hyperbaric oxygen therapy can also be used to treat certain conditions where there is retinal hypoxia, like central retinal artery occlusion, a condition that can cause permanent retinal damage. And this therapy can help restore and maintain retinal oxygenation, reduce edema, and preserve compromised tissues. It can also reverse ischemia-related damage if applied within a certain time frame. Other potential ocular indications where this hyperbaric oxygen therapy can be used in ophthalmology are again where there is ischemia or there is embolism. So these are the list of conditions where there can be use of HBOT. Contraindications are in asthma, in claustrophobia, congenital spherocytosis, COPD, eustachian tube dysfunction, high fever, pacemakers when a patient is on pacemaker, or there is an epidural pain pump which is there, seizures and pregnancy. So in these conditions, HBOT is not given. As far as problems with HBOT are concerned, generally it is considered to be a safe procedure, but though complications are rare, but this treatment does carry some risk. And the common complications which have been encountered are middle ear injuries, including leaking fluid and eardrum rupture due to changes in air pressure, temporary nearsightedness caused by temporary lens changes, lung collapse caused by air pressure changes, which is called barotrauma, seizures as a result of oxygen toxicity, hypoglycemia in patients who are diabetes treated with insulin. In certain circumstances, fire because of oxygen-rich environment of the treatment chamber have been reported also. As far as problems in eye are concerned, patient can have eyelid twitching, blurry vision, and visual field disturbances which are temporary. Temporary nearsightedness also can occur in these patients, which is caused by temporary eye lens changes. And many of these symptoms are thought to be caused by oxygen toxicity of the lens, which can lead to complications like cataract and myopia also. So as far as visual function which is to be seen in these patients, we don't have to monitor only the visual acuity in these patients. We have to consider the visual fields also. So visual acuity alone is not an adequate measure of visual function to monitor the efficacy of HBOT. Ocular examination after the administration of HBOT should include automated perimetry also to evaluate the central 30 degrees of visual field at appropriate intervals. Interpretation of the literature on the efficacy of HBOT in treating ocular disorders is complicated by several factors. There is frequent failure to include visual field examination as an outcome measure, failure to adequately address the interval from symptom onset to initiation of this therapy, and lack of evidence for optimal treatment regimens for essentially all ocular indications. Thank you.
Thank you, madam. It's a very good presentation. And that application, real-time application. So will you like to share with us where you are given in what type of patient you tried in CRAO patients?
Actually, sir, in India, the use is not much. Still, we are not using it much, but certain institutes have bought the HBOT chambers, like in Delhi. They have purchased, primarily Chennai people have started, and this Baba Research Cancer Institute.
Have you an experience of using it?
No, I have personally not used because we don't have this chamber, but I'm trying to collect the literature and so that we can, the benefit can be given to such patients where we can have.
Actually, Uttarakhand AIIMS Rishikesh has this hyperbaric, basically the plastic surgery, the surgical people, they use it. But you had emphasized on use in ophthalmology. CRAO was known to us, but others applicability, so I was looking for. Anyway, thank you very much.
They have claimed that even CRO patient can get benefit even 7 days after an attack of CRAO, if the therapy is given.
Okay, thank you.
Thank you.
I invite the next speaker, Dr. Arup Chakravarti. Arup Chakravarti, I hope everyone knows him. And he is a person originally from that Arvind Hospital. He was a mentor, trainer for cataract training, IOL training for several years. So several ophthalmologists, and I would request all the speakers to be please present till the end of the session. After they finish their talk also, then please stay back for other speakers' sake. Thank you. Thank you very much. So Dr. Arup would be talking on decades as a phaco.
Thanks a lot, Sanjeev, for the very kind introduction. Today we are witnessing an explosion in knowledge. Every other day some new technique comes up, new technology, new molecule, new way of doing things. So I am going to share with you how I have adapted to this knowledge explosion, and it is incumbent upon all of us, to move with the times, to ride the wave, so that we stay current and the benefits of all this new knowledge, new technology, and everything is passed on to the patient. So this is just an extract of how I have adapted to the situation. Earlier on, of course, whenever I used to travel, read, it was the physical textbooks, journals. There are a lot of expenses involved in acquiring those textbooks and journal articles and all. So today, 99% of all my knowledge acquisition studies take place through these websites. AIOS.org. It houses a wealth of information. AO.org, ONE Network, iWiki.org, cybersite.org, iConnectInternational.com, ESARS.org, ASARS.org. These are the sites I visit almost on a daily basis. So I will start off with AO.org because this is one of the most complete websites that I have ever accessed in ophthalmology. So it has a chapter, it has a section for the ophthalmologists, for the people who are engaged in advocacy, and for the public and the patients. Now, as regards the ophthalmologist, if you see this particular bar, it gives you a plethora of information. Let's say clinical education. For example, when I go to that, I could go to the journals, and you have access to more than 20 journals. So you don't really have to subscribe to, some of these prestigious journals like, American Journal of Ophthalmology, then ophthalmology, ophthalmology retina, ophthalmology glaucoma, and so on and so forth. You just need to be a member of American Academy of Ophthalmology, $400 per year. It has gone up over the years, but I think it's still a very nominal amount. And you get any article that you want immediately using your membership details. And then second thing, of course, they conduct a lot of pertinent clinical webinars and courses. As a member, you don't have to register for it, and these are all archived. So most of the controversial topics that we talk about, and some of the popular ones, if you want to see what is the evidence-based discussion done by the experts in the field, global leaders in the field, you can look them up in the courses. Focal points have stopped now, but the archives are available, the clinical webinars. What I find extremely useful was, when COVID came in, so WHO had come up with the guidelines. American Academy guidelines on COVID-19 was something unbelievable. They're so up to date. AIOS also was not lagging behind. Then preferred practice pattern. Some of these common disorders, evidence-based practice, it's not, we should not be saying, in my experience, it has, this medicine has worked well or that lens has worked well. You need to have a preferred practice pattern which is evidence-based and adapt it to suit your own practice. Likewise, ophthalmology technology assessment, newer technology that comes up, in what is the relevance, whether just research tools or whether they have practical implications in your day-to-day practice. And then there was a lot of discussion on premium IOLs. This is about 2 or 3 years old, this particular section that came up. So you get current literature, even the FDA report, everything. You don't have to depend upon the sponsored talks by speakers or the company executives, company representatives. And then there's a multimedia library, all sorts of videos. You just search in the keyword and it shows up. There are different formats, 1-minute format and the longer formats. Everything is there. And then a bit about ONE Network. ONE Network was, it is Ophthalmic News and Education Network. Now, as a member, I get full access to it. But I think about 1 or 2 years back, AO had a tie-up with AIOS where, many organizations like AIOS had, free access to the ONE Network. Somehow it has been withdrawn, and I sincerely hope that AIS membership, AIS leadership takes it up seriously, so that about 26,000 Indian ophthalmologists, just through the AIS membership, can access all the benefits that I have been talking about. And there is also an option, like if your society is not registered, you can individually write to this email address, your circumstances, you are a teacher or whatever it is, financial issues. So it is also made complimentary. I have come across some people in Africa, when I go for the academy meetings, who access it without becoming member of the American Academy of Ophthalmology. So this is basically what the ONE network does. I'm not going to, elaborate on that, what I've already discussed. Second thing that is extremely useful is iwiki.org. Now, if I'm presenting on something new topic, sometimes it happens that, it's not my field of expertise for the last couple of years, but still I want to present something. So this is something which is absolutely up to date. This is a collaboration with an American academy and more than a dozen societies. And it keeps on changing. And it doesn't give you the very latest in details, but you get an overall idea as to what is happening, and then there's a bibliography. So then you can look up the cross references. In 2 or 3 days' time, in a particular section, you should be able to make your own presentation on that. So it is extremely useful. And then the ICO, their website, cybersite.org, they have very frequent webinars. So all these lectures, surgical videos, quizzes, manuals, and what I really look forward to is their webinars. And sometimes, these webinars, it's like when I'm traveling and I'm not able to attend it live. So I've created a subfolder in my email. So they send the recorded version. So I save it in the recorded version. And whenever I get the time or when the interest up, the need for that arises, I look it up. And this is all recorded. So for example, a couple of years back, a lot of formulas have been coming up. If you see now there are about 30, 40 formulas in addition to Barrett or, the Hills RBA formula and Kane formula. So a lot of formulas have come up. So it gives a very good review about, how to go about confronting those formulas. So then the AACRS used to have a very vibrant, very energetic discussion forum. And can I take a little more?
Yes, please,
time?
please.
Yeah, thank you. So, it was a very vibrant forum and people used to come up. I had a problem with this particular lens, with this machine, and very frank discussions. But then AACRS, like many organizations, are heavily sponsored by these multinational giants. So those speakers used to be blacklisted, some of them will be ejected out. So now a group of people, they got together, made iConnect International, and it is of course sponsored by few companies, but it's a free-for-all. You maintain, of course, the personal dignity and respect for each other, but you can post anything clinical, complications that you have had your experiences, so on and so forth. So for example, now there's a discussion was happening on IC8, the new lens, the small aperture lens, YAG capsulotomies. How do you do it? YAG capsulotomy. So like that, I again create a subfolder whenever I'm not able to come online when the program is going on. I created a folder and now see when I have a time. So for example, this particular discussion which is current now is Johnson & Johnson has discontinued a particular type of very popular lens in USA, which is still used in India. Astigmatism, accuracy of diagnostic, machines. So basically you have the leaders, the world leaders talking about their own experience. You have, Warren Hill participating from this side, Graham Barrett is participating, and everybody, you get to know it's sort of not a one-to-one discussion, but it is a very useful discussion that happens. And of course, I wrote edited 3 books that are available online also. So then another important information I would like to give you is our AIS proceedings website. From 2017 onwards, all the deliberations, most of the presentations have been captured. They have been put up in the website. I started it off. Initially, there was a lot of opposition from the home front, unfortunately, but all those I could tackle, with a lot of perseverance and, with negotiations and things like that. But now it has become a reality. So yesterday also I was talking to one of the cornea experts. He is telling, Arup, it was so useful. When I want to preparing a talk or want to have some doubts clarified, I use a particular keyword, which way I want, and then I get access to all the presentations that have happened in AIS over the last so many years. And I'm pretty happy that the new person who has taken over this post is continuing the same thing in the same format. So it's a very good thing. Please visit the AIS website. And these are some of the other websites that I have been visiting from time to time. The Medscape, once you register, they keep sending you all the latest discussions, latest controversies and all that. And so there are many such discussion forums that are, available. irounds.org, like for every institute has a website. Every famous institute in USA, they have a website where all the stalwarts who writes textbooks, who are on the cutting edge, who discovers new things, they basically, talk in the website. There are webinars, and there are a lot of archived items. So, I mean, as you experiment online, you find that a lot of useful websites are coming up. So this is basically how education has improved. And now I don't really travel with any extra luggage. I have all these things available on my smartphone or my tablet, or when I go to the hotel in my I can make presentations. So this is the way after 3 decades as a cataract surgeon, as a practitioner, I have adapted to the environment, adapted to the world that is changing and helping me to keep to stay on the cutting edge. Thank you very much for your kind attention.
Thank you, Dr. Arup, for a nice demonstration and bringing us this information to everyone, to the house. If someone has something to ask to him, one can discuss after later on. Meanwhile, we invite Dr. KPS Malik. He does not seem to be here present in the session. I invite the next speaker, Dr. Rinki Agarwal. After Rinki, Dr. Manisha, you are Dr. Rinki, please. After that, Dr. Manisha is here. Okay, after that you. Dr. Rinki would be talking on adding a new feather to your cap, overcoming the mind block.
So I'm going to share my experiences. When I was an SR, I was trained in cornea, cataract, refractive and ocular surface. So mainly I was an anterior segment surgeon. So after that, I was in AIMS at that time. After that, I joined Guru Nanak Eye Center, and there I made an attempt to learn strabismus and oculoplasty. So how and what experiences I have to share with all, my take on how to shift from an anterior segment to strabismus and oculoplasty is something that I would like to share today. So from where to learn, so whenever I started when I started of thinking that I have to make an attempt to learn strabismus and oculoplasty. So first we have to choose a high patient flow center. Thankfully, Guru Nanak Eye Center is a very, very high flow center. So you have many patients to learn, and be open to all learnings. For example, learn from everybody, consultants, juniors, seniors, peers, patients, yourself, YouTube videos, everything. But then we have to understand that YouTube videos are a little passive. You cannot discuss things with them, so which you can discuss with experienced surgeons. So ask questions, ask everybody whatever you want to learn, clear your basics, and most importantly, there is no shortcut to it. You have to read renowned books. Okay, high impact journals, read anatomy again, because you have to start from anatomy in the beginning. Okay, you cannot escape that. Whatever YouTube videos you watch, whatever people you talk to, most important is reading by yourself. Okay. So then you have to focus on the examination. So as an anterior segment surgeon, the focus will be mostly on slit lamp examination. But in case of squint and oculoplasty, you have to examine the patient grossly in natural light. Because, for example, this lesion you can see in natural light, the lesion is very much pigmented, but under slit lamp examination, magnified view, the pigment is almost masqueraded. So you have to make sure that you understand this natural light examination importance. But still, slit lamp examination is also mandatory in cases, because you may miss out marginal entropion, punctal stenosis and all, and you will always keep looking for causes. So then make sure you examine the patient in sitting position and not, and apart from, because entropion, ectropion, symmetry of iris, everything that can be measured better in a sitting position. So for example, when one patient I operated an entropion, ectropion, the patient had ectropion, and the moment that I made the patient lie down, I could not appreciate the ectropion. So at that time I understood the importance of examining the patient preoperatively in sitting position and planning at that time only. So syringing and probing holds very important part of examination in these cases. Whenever there is any lesion near your medial canthus, you have to always make sure whether the puncta and the canaliculus is involved or not. So for investigations from biometry, I shifted to imaging. So for anterior segment surgeon, I had this corneal topography, tomography and biometry, optical biometry. But here I had to focus more on ultrasound, B-scan. I learned water bath, ultrasound, UBM, color Doppler, MRI, CT scan, PET scan. And rarely sometimes I even I also performed AIOCMT3 for muscle thickness and muscle insertions. So and apart from that, unlike only in anterior segment examination where we could focus on RBS and BP, here I had to focus on bleeding time, clotting time, platelet count, sometimes even PT-INR. So these all are important, and universal precautions hold more importance in this case because there's a lot of blood oozing happening in this one. Then, as I said, examining position, you have to make sure you have to have the cooperation of patient during ptosis surgery for entropy and ectropy to see how much of it is corrected at the same sitting, and you can augment it or change it in the same sitting when the patient is in the operating table. So most important in these cases is to set the expectations and outcomes. So you have to sit with the patient and talk to the patient yourself. Okay, unlike intraocular procedures which are site saving, extraocular procedure usually cosmetic. But yes, cosmesis does matter. Even if we have one pimple, we become so conscious. Imagine people living with squint and bad cosmesis for so many years. Their social life is completely destroyed. They do not get jobs. They do not get married. So that's why even maintaining cosmesis and giving the patient realistic outcomes, expectations, matching with them is also important. So you have to sit with the patient yourself. Hear what the patient desires and explain to them what you can offer with your procedure. So margin of error is a little more. You can let the natural healing take its course and still be a little less precise with it, unlike anterior segment procedures where you have to be more precise. With experience you obviously get more sophistication. So beginning, choose simple cases and then shift to more complicated cases. And most importantly, collect your own pre and post photographs for cataract and all, which will not be necessary, but here you have to have a preoperative photograph and a postoperative photograph, preferably in the same position, same lighting, same background, such that you can always show it to your next patients that this is the kind of outcome I am going to offer you. Then intraocular procedures as well as extraocular procedures both can be done at the same time, but and in extraocular procedures we usually operate both eyes together, either it is entropion or ptosis or squint surgeries and all. It is always preferable to operate both eyes together, unlike intraocular procedures where you operate one eye at a time. Okay. So shift piecemeal, small things matter. Shift in a small way, for example lying position. Okay. Then orientation, you have to shift from temporal to superior position for oculoplasty. For squint we'll have to change positions, sitting temporally and then right eye, left eye accordingly. Then anesthesia, you have to shift from topical to local anesthesia, learn to give infiltrative anesthesia, nerve blocks. Then cleaning and draping, where for intraocular we were using 5% betadine, here we'll have to use a little higher concentration of betadine, 7.5% to 10%. Then we may not need operating microscopes. Many oculoplastic surgeons don't like using operating microscopes. You can use loupes, or you can also go for naked eye surgery. From 10-0 monofilament, very thin suture, you have to shift to silk and vicryl. So that was also a little change for me because they are braided, they leave threads and all. Then scissors also, from the smaller scissors, vanas, and I had to shift to conjunctival scissors, stenotomy. So completely change of my motions, hand movements was something that I learned. New ways of handling instruments. So most importantly that I faced a problem, lot of problem was blood. Unlike anterior segment procedures which were like very clean and neat, and next day there was no redness, it was all white. Here I had to see all blood, hematomas were forming, intraoperatively all the blood. So I had just learned in the beginning, I used to be scared, but then I learned I should not be scared of this blood. It's quite a normal part of the surgery. So preoperatively we have to prepare the patient in such a way that the patient does not bleed much intraoperatively. You can go for hypotensive anesthesia, sedation, control BP, adequate pain control. You can use adrenaline soaked swabs, cautery, pressure patch suture, and then especially in case of DCR, nasal packing with xylometazoline, adrenaline soaked swabs, they really help. So try to control bleeding in the preoperative phase, but if it is not possible, then intraoperatively don't be scared of blood. It is a part of normal process of squint and oculoplasty surgeries. So this is the previous work that I have done, removing pterygium, managing PUK with conjunctival recession and AMG. This is caruncular mass excisions, even medical management of microbial keratitis. This is the case of fungal keratitis which heal with medical management. This is PKP with SFIL that I have done before. And from there shifting to oculoplasty procedure. So you can see that I have this patient, one patient was there young patient who had hemangioma, and then I excised it and it was quite healing well. This is 6 weeks photograph. A ptosis surgery patient, you can see favorable outcome in patient with senile ptosis. Then this was bilateral entropions that I operated. This is one more patient with blepharoplasty. This patient was having punctal occlusion because of this fat pad prolapse. For him I did blepharoplasty, and then the patient had quite a relief in watering. So this I started with these large angle squints first. You can see, and then I shifted to very small angle squints, complicated ptosis with squints, sling surgeries and all. And I started having quite a reasonable outcomes. I used to get my cases checked with others in the field, for example, oculoplasty surgeons, whoever I had SRs or JRs or whoever were more experienced in that. And then I used to ask them, what else can I do? What else can be more? I used to show the patient before planning surgery what can be done. So even combined surgery, we can then I started moving to combined surgery, where I used to do extraocular procedures first. Then with little less manipulation, especially during squint, you should make sure there is no scleral perforation, because in that case hypotony will be there and you cannot do the intraocular procedures. Wet the cornea, don't forget the cornea in these procedures, because you have to perform an intraocular procedure. So these kind of surgeries are quite cost effective and lead to less visits for the patient, less post-operative morbidity and all. So then you can offer both of them, vision plus cosmesis to the patient in one go. Squint surgeries can be specially undertaken in post-amblyogenic age, where we don't expect much of improvement in vision. So I previously published this paper, triple procedure for coexistent aphakia, squint and iris defect, where we undertook strabismus correction, gluteal and single pass 4-through pupilloplasty. This was like when I was an SR in 2022 or 2020, I got it published. At that time I did not do the squint, but now I can tell you that if somebody asks me to do this, I'm self-sufficient in doing this, all the 3 procedures. Okay. So this is what makes me feel proud. Okay, these are the combined procedures that I have done. This was a young female with bilateral aphakia for congenital cataract. She was operated with squint. I did squint surgery with secondary eye implantation in the same sitting. This was another Buddha Baba with paralytic squint for facial palsy, where I did ectropion, lateral tarsal strip, lateral tarsorrhaphy and AMG procedure together, and he was quite responsive to that procedure. This was another patient who had acute trauma, and after that I did lens aspiration with corneal repair, SFIL and
Dr.
cheek plus.
Rinki, your time was over.
Yes,
Before,
just.
please.
So final take is that what matters is that you should be open to new learning. It's not just acha dekhna, but acha dikhna also matters. So my entire viewpoint changed from just vision to even cosmesis, which I thought was not significant before. So experience is best learned, and it's not just taught. You have to make an effort for it. Thank you.
Thanks a lot, Dr. Rinki. Your transition story was very enterprising, very inspirational. Normally what happens in a private practice scenario is, as a surgeon, you have reached the pinnacle in whatever field. And then when you take up something which is absolutely diverse, obviously there is a learning curve involved. And if one is not able to deliver equivalent results, it becomes a sort of a mental setback for the surgeon.
Definitely, sir.
And these are all private practitioners. But I'm really amazed that, you have, overcome all these things without much problem. And it's not very often that, this kind of, expertise or enterprise is seen. Very good presentation.
Thank you, sir.
With this, she would be talking on AI in ophthalmology, changing paradigms.
So it's artificial intelligence in ophthalmology, the changing paradigms, how it is affecting our lives. So in this presentation, I'm going to tell you a little overview, and then AI as game changer in ophthalmology and in various aspects like diabetic retinopathy, ROP, ARMD, RD, in glaucoma, anterior segment disease, and so forth. So what is artificial intelligence? It's the study and development of algorithms that give machines the ability to reason and perform cognitive functions such as problem solving and decision making. So what is this? We often see this diagram. This is an input layer where a lot of information is put in the machine, and in the hidden layer that there is a deep learning procedure where there is a phenomenon called black box phenomena also, and this all information is taken towards the outer layer, and this is the output layer which we get as the final decision of the machine. So in artificial intelligence, there are various subfields like machine learning, deep learning, and convolutional neural network. Machine learning, it enables the computer or the machine to learn from examples from being explicitly programmed. Deep learning is the inside story of the machine, which it learns of itself, and neural network, in this, there is automatically the machine learns the spatial hierarchies of features, and the images are put through various convolutional operations. So how the algorithms are prepared? There's a data training set, first of all. A data set is used to teach an AI model to recognize various patterns and make predictions containing labeled examples of input data and their corresponding outcomes. Then there is a validation set over and above this input in the machine. A set of validation is, there is a data set which controls this and trains the machine and ensures that there is a generalization of the unseen data and it does not overfit. The major steps are the data collection, there is a pre-processing procedure, then there is a feature extraction, and the diagnosis and prediction of the final picture is taken thereof. So each step up, it adds value. From data, it goes on to information, information leads on to knowledge, and finally the machine gets the wisdom. So something like what we learn in human life. So there are various available systems for various disease entities like DEEP, ROP, IDEX, DR. They are for different entities like diabetic retinopathy, macular pathologies. We have Deep Minds, the Peak Vision system for analyzing smartphone images, what we get, and Topcon Aladdin slit lamp for anterior segment diseases. So then the overview, it's ocular diseases are a significant cause of visual impairment and blindness worldwide. Early detection and timely treatment is crucial. Traditional methods, they are very time consuming and labor intensive. We require a lot of people who are trained. AI offers consistent, repeatable results without the fatigue. So what are the challenges? The manual diagnostic limitations, as we know, human error is always there. Could be a fatigue phenomena. We don't have so much manpower. High demand for eye care specialists are required in the peripheries as well. So AI it's a game changer in ophthalmology. It's a buzzword everywhere it is used nowadays. So what is this all about? There's an early diagnosis and risk stratification. AI-assisted screenings are there. Telemedicine platforms have been formed. They are very accurate, and with the things are done with speed. There is a scalability and cost effectiveness of this procedure. I don't know, in India, yet to have a lot of machines, but in other countries, in developed countries, there's a lot of AI working for ophthalmology. So it also helps in predicting the disease progression, treatment, and outcome. So there's a growing burden of retinal diseases in various aspects. This is the slide showing incidence and prevalences of various AI in retinal diseases. So I'm going to tell you a little bit brief about these entities. So AI in diabetic retinopathy, how we are doing it? By color photos, OCT, FA, and OCTAs. We grade the DRs, we identify the DMEs, and identify the NPDRs and PDRs, and find out who's healthy and who's a diabetic patient thereof. AI in color fundus photographs, we start from the input, convolution, deeper layers, max pooling, and the output, as I told in the beginning. So same is with, we have a lot of images taken from the fundus from various data is collected, and then neural networks will be applied, and deeper learning will help to find out what are the hemorrhages or exudates present. And finally, a picture is told to us that this is the final picture, and this is the stage of the disease of diabetic retinopathy. And so OCT also. OCT pictures are also fed as the fundus images. It helps in diagnosing DME, predicting the treatment responses. And we know the various layers. OCT will tell you what cystoid space is, as SRF is there as not, and what is the stage. Again, we can know what we can morphologically also see what OCT is telling us by this AI. AI and OCTA angiography similarly will help early identification. We can have a ischemic index. We can have vessel density significance can be visualized by these AIs. And then is the fluorescein angiogram. It also helps to find out what is the leakage, what is the microaneurysm count, and the CNP areas. Then is in ROP. ROP we need bigger machines. It's a little difficult because we have to take pictures in small children. So it is a little difficult procedure as compared to DRs, and it has to be done in NICUs. A lot of good cameras are required because the ROPs in the peripheries, they have to be taken with the bigger cameras, optos, and something like wide field. And it is having some challenges as compared to the adults. So ROP screen is done with a deep ROP system. It has one ID net system and GR net. It identifies either ROP is there or not, ID net, and GR net will tell us whether there is a minor ROP or a severe ROP. So plus disease is also found out with this ROP screening by AI. Then in AMD, It is the screening and diagnosis, which is helps in timely detection of ARMD. And various algorithms are available for ARMD. AlexNet and Google LayNet also helps in predicting the visual acuity in ARMD, predicts the necessity whether we need to have anti-VEGF injections or not, using image biomarkers along with socio-demographic factors. What are the conversions from dry ARMD to VRMD? It can be predicted to some extent. Then AI in RD. So ultra-wide field imaging modalities, they are used. The program is Inception ResNet V2. At first step, it defines whether there is RD or non-RD, and then it tells whether it is a macula involving or non-macula involving. And this is how it is screening the things. And finally, it will give us information regarding preoperative posting of the patients, whether it will go to further progression or not. And whereas limitations are there with these AI systems, the cost, high resolution, wide field imaging modalities are required. Lesser research and emphasis has been made, can miss out on subtle lesions like retinal holes and lattices in the periphery, and we can miss the peripheral lesions. Then in glaucomas, OCT can help in finding out, detecting and quantifying the RNFL thinning and optic disc changes. Visual field interpretations can be made. Risk stratification models can be known by knowing the genetics, history, IOP, and treatment responses. Teleophthalmology in remote areas by analyzing the fundus images and visual field defects, visual field tests can give us information regarding the glaucoma in a certain patient. Then in anterior segment diseases also it has worked wonders. Corneal tomography and topography can be done in keratoconus, and in knowing the thickness and abnormalities of the anterior chamber, cataract grading can be made out. We can optimize the IOL power calculation, and dry eye meibomian gland changes can be seen. A recent article in International Journal of Surgery, there is a study which is done in China, and it tells that 182 videos were taken of cataract surgeries of different surgeons, and they've defined 12 steps. So you can feed your surgery steps into that AI system, and it will tell deep surgeries it will provide a real-time supervision and objective surgical evaluation system for routine cataract surgeries, improves the quality of surgery, and you can reduce the demands on a senior ophthalmologist trainers for surgical guidance. So it may form the basis for establishing a standardized and efficient cataract surgery workflow. So it's a really nice article to be read. Then what challenges we face with artificial intelligence? It often lacks diversity, leading to inaccurate results when applied to different population groups. Something which is applied to Africans or Americans may not be true for Indians. So there is a lack of human touch, this lack of infrastructure, particularly in developing countries. With limited internet, it hampers the effective implementation of AI systems. And falsely labeled laser marks, sometimes they can tell you that these are the local pigmentations, and we can be in trouble. It can tell us something different what a human can see. So limited accuracy where media opacities and artifacts are present. This is the limitation. Current AI systems can monitor only one disease at a time, making it impractical to switch between multiple systems, especially in resource-limited settings. Depending on the artificial intelligence, we may reduce the physician's decision-making skills and critical thinking. Data privacy concerns are there, definitely. Accountability for errors. Who knows? If the machine says something and the patient is not having, and we start treating the patient, that's a very challenging and questionable thing for AI. And then is the black box phenomena. We really don't know what the machine makes its own decisions sometime, which may be difficult to handle. So what is the future of AI? It is an expanding access to the remote diagnostics. AI integrated contact lenses can be there for 24/7 IOP monitoring in cases, especially in glaucoma. AI models can combine retinal images with genetic lifestyle and demographic data to create personalized treatment plans. So AI is revolutionizing management protocols, particularly in the areas of early detection, accurate diagnosis, and monitoring the disease progression.
Thanks a lot, madam. It was a very comprehensive overview of this complex topic, leaving very little scope for any discussion. I think our first exposure to artificial intelligence as anti-segment surgeons happened with HEAL RBF file power calculation. It was entirely based on artificial intelligence, and then of course the Kane formula and some of the newer formulas, then glaucoma progression analysis. But then this is an expanding field, and I think in future will determine, you know, what will be the human component in, you know, in the management of the many disease conditions where AI is used to
Quite
an
interesting,
extent.
and
Yeah.
though it had started in 2000. If you see a lot of YouTube videos, there's a lot of, I said, it's a buzzword.
Yeah.
We are already using it quite a lot. And we don't know where we are going to land a few years from now. People say after 2030 or 2040, human doctors will not be required or something like that. But some people say, no, it won't happen, ever. So controversies are there. We are already using so many places. When we Google the things, we get so many articles in one go, in one touch. So AI is happening everywhere. Siri, Alexa, everywhere AI is there.
Yeah.
So we were there using it for a long time, but...
So thanks a lot. So now we come to the final
Sir,
talk.
Happy Diwali. My last slide was a Happy Diwali thing to everyone here.
Okay.
इन्होंने बंद कर दिया. वो दियास दिखाए थे मैंने.
Happy Diwali.
Happy Diwali to all.
It is November 1 or 31st?
So that's also controversial.
Hey, celebrations have not yet started.
It's the 31st.
Arvind, we haven't
Dr.
started
Maurya,
the celebration. Okay, so now Dr. Vinita, expanding your horizon, navigating the path to international examinations.
So obviously this talk was mostly for younger generation who would be looking for international examinations, but I don't find many people sitting here. Still, I'll talk about it. I'll be going very brief about it. So basically, why consider international examinations? It gives you enhanced career opportunities outside India. You get access to global jobs, as I said. It recognizes your skills outside India. Even in India also, it gives you credibility and validation of your expertise. It gives you more network opportunities of interacting with your international peers and mentors. And besides that, the thing which I gained, it gives you a personal growth and a lot of confidence. And obviously, if you're looking at international markets, there's a very, very high scope of increasing your earning potential as well. So for the knowledge and the skill aspect, as I said, for me, this was a thing which, when I started taking my exams, this was the first thing which I realized it dramatically changed my knowledge perspective. The way we approach patients, the way we take the examinations was very, very different when I took my examinations. From India, it was very vastly different. So those tips I have still, and it became a part of my daily practice of using those tips which I learned while taking my own exams as very practical tips for me. And it has also helped me in continuously updating and upgrading myself because of the various websites and various links which are available to me as a fellow of their colleges. And also enhance my writing skills for the exams as well as the communication skills. So these are the added advantage. Now, before anybody plans for it, one has to decide how much time to have. Is it worth it? Because it requires a lot of money, time, and the zeal, obviously. Does it add to my qualification? Are you actually looking for it? Is it just another exam? And when should I apply? So, as I've already talked about, lots of pros, which are the different levels of knowledge, better job opportunities. You get better job opportunities, especially in the teaching and education institutions outside the country as well. For me, it was joy of giving exams as well, and the post-nominal degrees, which you always get after your name. So you get to add so many things. But the negative downside of it obviously is the cost. These exams are all costly, especially considering our currency differences. So common challenges which you'll face if you're planning to move out with these exams is obviously adapting to different cultural environments outside your country. The language barriers maybe there is for some of the countries, not always, because most of the countries are English speaking. Balancing work and study, because out there, unlike in India, we get lots of servants to do our works or help for us, which we will not get outside. And the most important challenge which you have to while taking the examinations is to step out of your comfort zone, because you'll have to manage all the things together. So before you apply, do a lot of observation, do a lot of research, and then plan who are your role models, what are you looking at, that you have to first decide. Which examination, which country are you planning to go to if you are planning of a long-term future to move outside India. So looking at these various international examinations, we have the fellowship examinations in the Royal College from United Kingdoms, we have it from the Australia, and we have from the American board mainly. And understanding the exam format for most of these exams is similar. They have initial written exams, which could be in the form of multiple choice questions, some essays questions, and then we'll have their oral examinations, with a clinical component as well as an OSCE type of component, which is like more of a structured oral component. And then it is important to learn how to pace your exams, because these exams can be taken at maybe in 1 year you can finish the entire exams, or if you want to pace them at a slower pace, that you have to decide for your own self. Preparing for examinations, you have a lot of study resources available, recommended textbooks, online for each type of set of examinations, access to various question banks, test papers are there of the past. Then there are various study groups which have been created, which are there, and lots of clinical training groups are also not there. And in fact, in India, with a group of people have started conducting courses which are for the oral exams as well recently. So and also if you attend various workshops and seminars where we talk about these courses, that's also happening. It depends, like people in some places are being given institutional support. Like I have known people somewhere in Arvind and all, they were getting some institutional support for taking the basic exams, if I say part 1 and all. I don't know whether it is there right now. I'm talking about almost 10 years back, they had some institutional support. Otherwise, you have free online platforms, you have paid online platforms. And outside the country, there are some people who do get, even if people from UK, if they're planning to take some US exams, they get some support from their own institutions. So let's talk about the US thing, the fellowships. Overall, the quality of training is obviously very good out there, and it gives you a very, very wide perspective of things. They have long-term fellowships, they have short-term fellowships. Whether you want to go just for fellowships, whether you want to go for residency programs, it would totally depend upon that. For fellowships, for US, it is mandatory to have a USMLE if you want to do ophthalmology. So you have to have USMLE or a certified ECFMG, as we used to call it earlier, which is mandatory, and except for people from California and Pennsylvania, or people try to go to Canada, because if you get a Canadian degree and then go to the Canadian route, then the US people do not ask for your ECFMG. So that is the exemption you get. For Canada, obviously, people are more from India. It's easier to move to Canada as compared to US. It's extremely friendly, and it's more of an Indianized. Since I've been recently to Canada, I realize it's more of an India. It's like the second India there. So direct applications are also accepted out there. So that's the advantage of being there. And once you get the College of Physicians and Surgeons of Ontario licensing, you can practice there if you want to settle back there. For England, it is the most favored because, first of all, the language issues was not there. Then the courses available are widely available. And nowadays, the biggest advantage is they have started conducting all the exams in India. So you need not waste your money on travel to take the exams, which I did in my times when I took the exams. And also, a PLAB is not required anymore now. So it's even if you're taking direct examinations for ophthalmology, FRC Opt or FRCS of Glasgow or Edinburgh, you are exempted for PLAB if you want to go and practice later on there. Then we also have the Singapore, the Asian academies, the Singapore and the Hong Kongs, which are giving the Asia Pacific Academy of Ophthalmology fellowships. And again, the FRC, but in these, the added advantages, we already have the UK degrees, you are exempted. You can directly just go into the system and get the license. So that is the advantage if you have your UK fellowships. For Australia and New Zealand, again, that is the advantage. If you have your UK fellowships or UK qualifications, you can directly go to Sydney, Australia and New Zealand. Otherwise, you can go to the direct system as well, but through the RANSCO, which is the Royal College of Australia and New Zealand Physicians. Dubai, again, you have a single fellowship exam. You can go through the ICO route, or you can go through the FRCS and the FRC of, again, the UK fellowship examinations. And if you're going to UAE or Dubai, any of the places in UAE, you get an extra edge in terms of your money potential, job opportunities also. Because if you're going from India and you do not have the UK fellowships, you are paid less as compared to a person who's paid better if you have a UK fellowship. So that is an added advantage for UAE if you're planning to shift to UAE. And these ISO fellowships obviously give you an added advantage because it gives you some exemption from the part 1 of the FRCS examinations. And also, if you want to go and actually do 3 months fellowships, it gives you a free access to those 3 months fellowships, which are short-term training for a subspecialty training. And then we have various institutes which offer you long-term research fellowships. I've listed the premier ones out here. Most of them are from US, and the one in UK is the Moffitt's Eye Hospital. So this is just a chart where whether you want to go to England. As I said, PLAB is not required now. If you can directly take MLE, would still be required if you want to move to US or Canada. RANSCO is for Australia. And for Dubai, again, you can just directly, within FRCS, get an exemption there. And same was for Singapore, direct applications are allowed. These are the various websites I've just listed there for various colleges. So you can, if you want, you can have an access to these, all the information which I have told you is available on the websites of the individual countries. For the Royal College, since I am trained, I have all taken my Royal College examinations as well as the Royal College of Physicians and Surgeons of Glasgow. So I'll just giving an advantage of it. As I've already mentioned earlier, that it gives you a better remuneration in the Middle East. It's accepted valid degree in all the Asia as well. Then also in Australia and New Zealand. Then, and obviously that's your post-nominal initials as it did for me. So for the fellowship examinations, these fellowship examinations, earlier we had the MRCS. FICO is still there, which is a 3-step examination, part 1, part 2, step 1, step 2, and step 3. And step 1 is basics. Step 3 is basically the advanced MCQs, which allows you to once you clear this, you have an access to the fellowship of 3 months, which I told you, given by the ICO, the International Council of Ophthalmology. And also it exempts you from the part 2, the first step of part 2 of the FRCS Glasgow and Edinburgh. So let's talk about the FRCS in Edinburgh. It is a 3-step, again the 3 exam pattern, part 1, part 2, part 3. Same for FRCS Glasgow, part 1, part 2, part 3. So part 1 is basically MCQs only. Part 2 is MCQs plus a problem-based questions, which is sort of an essay questions. And part 3 is totally orals, which has 2 components, as I said, a structured component, which is oral vivas, and a second part, which is actual clinical exam when you're dealing with the patients. And for the FRC of, again, they have a part 1, which is, again, totally a theoretical exam, but again, it has lots of practical questions. The part 1 of FRCS is different from the part 1 of FRC Opt in that way that part 1 of FRCS is only basic ophthalmology, basics pathology, basic everything related to basic sciences. But in this part 1 of FRC Opt, they're all actually adding all equipment at armamentarium, which we deal as equipments for our ophthalmological examinations. So you're supposed to know the basic principles as well as the interpretation of those. And then we have the part 2 for this. This has only a part 2, and in between that they have a refraction certificate. So this is the added thing which is there in the FRC Opt. They want to ensure that you know your refractions also very well. So they have a part, in between the part 1 and the part 2, there's a refraction certificate which you have to clear, and then you have the part 2, which again has a written and an oral component. So these are the advantages of taking these exams. If you want to work outside, as I said, obviously your salary structure will be much, much higher for these various fellowships things. So if you're ready to take the plunge, it is better, So these are the various types of remuneration you get when you're doing the fellowships. If you want to take their exams, and once you become a consultant, the remuneration almost triples from these, what you get during the fellowships. So in the end, I would just like to say, once you're ready to take the plunge, embrace the challenge, you have to plan well, you will need help of your family, friends. You want to decide whether you want to build a career out of it, or you're just taking it for, as I did, for adding my nominal degrees or nominals to my degrees, and for the fun of taking the exams, and for purpose, the main purpose was for learning. Chart a timeline. ICO, if you have, as I told you, it will be an asset. Talk to people who have had their successes in these exams, because these are the success stories which are very, very motivating. Take experience from your own alumni who have taken these exams, take away from the journeys, and finally, you would be able to make it. Thank you. Because in the end, there's always light once you have the motivation. Thank you. Yeah, that's how I said. See, you have to plan well. Fear of failing is there because they have almost 1/3 only pass. 1/3, in fact, 20% pass rate when I take my exams now. Since they're counting, since I'm an examiner for the exams being conducted in India now, what I've realized, there was a system called as Hofsey scoring method, which is basically they analyze the data of the previous exam, they give the marking, and then okay, this is the lowest mark, this is the highest mark. And based on the probability, how much were below and then there's an average, how much were below, how much were above, they mark each question accordingly. This is the Hofsey method which they use. So for the Indian system, because the guidelines which are laid down by the Royal Colleges are very different from what we pursue in a normal practice. So those guidelines, there you have to answer each and every management according to the guideline which is given by the colleges, because that is how they practice. Here, even if the candidate is not answering, we give a leverage to that. We are told to give a leverage for that. So that's why it's become a little bit easier now, I would say that.
Acha, Dr. Vinita, you just mentioned that pass rate is 20% to 30%.
Yes.
Okay. So those 70
Sir, in
to
India
80
it was 50% last time, so it has increased.
No, so then what happens to the other candidates who have not been successful? They leave this course or they
No,
stay
sir,
on?
those who are in the system, because for people who are studying and doing the
Yeah.
residencies in the
So
system,
sooner
they
or
will have to
later,
complete
sooner
it
or
because
later,
they're-
everybody will complete it. Just that they'll require multiple attempts.
Yes,
to,
yes. This, so you have a, they will continue to take
Yeah.
attempts. And
Uh,
for people in UK, I know the system, if they are given a minimum chances of 4 attempts, and for every attempt, a feedback goes to the trainers
Okay.
to improve upon their performance.
And
So
another
that
point,
feedback goes
another
on for the residency program, people who are already into the residency systems there.
Yeah. So another modification is required in the slides when you mentioned about Canadian visa. I was talking to Stevie Archinov. He is supposed to come for, the Rohit Om Prakash's meeting and other meetings. He said very difficult to get a visa from Canada. So now things have changed. So your slide said it is a cakewalk and all that. It was earlier on,
Yeah.
but now they just don't let you. It's a very,
So this
very
is because
difficult.
recently it has happened because of the
Yeah,
Canadian
yeah.
thing, no?
So that is it.
Yeah,
So next talk.
recently. Recently it has happened. It's happened just 1 month back. We had a problem in our WOC present. For everybody, it was a problem.
So thanks a lot. We had a very nice session.
No, for me it was learning also. I learned a lot. I would say the best thing I did was I learned a lot from these.
With this, thank you all the speakers, and with this we conclude the session. Thank you.